This is a pre-recorded presentation, so the presenter will not be taking any questions. However, all questions asked during the live presentation, along with answers, are included at the end of this presentation. To learn more about our upcoming patient and family conferences in your area, please visit aamds.org/conferences. To view other recorded presentations or to register for other live online learning events, please visit aamds.org/learn. Welcome to our live webinar entitled, What is Peripheral Neuropathy? Understanding the Causes and Symptoms. Thank you for joining us. My name is Angie Onifred, Director of Patient Education at AAMDSIF, and I'll be moderating the presentation today. As we get started, I would like to acknowledge the generous support of Celgene and Takeda for supporting this webinar program. Today's presenter is Dr. Christopher Callagan. Dr. Callagan completed his medical degree and neurology residency at the University of Pennsylvania. He also completed a master's degree program in clinical research at the University of Michigan School of Public Health. Dr. Callagan's clinical and research interests focus on peripheral neuropathy. With that said, it is my pleasure to welcome Dr. Callagan.
Thank you so much. Look forward to hearing all the interesting questions, and with that introduction, I'll just start into the talk. So the title of my talk is What is Peripheral Neuropathy? Understanding the Causes and Symptoms, which is what I was asked to talk on, and we'll hit on a number of different areas. So here's the outline. First, we're going to define what peripheral neuropathy actually is. Then we're going to talk about what causes it, particularly in someone that has a bone marrow failure problem, such as the different diseases that your organization deals with. Then we'll talk about symptoms of neuropathy, things that might warn you that you might be developing a neuropathy, and then the kind of evaluations and tests that should be done or could be done in patients that have these symptoms. Then we'll talk about nerve pain treatment, which are oftentimes our best treatments for neuropathy. And we'll end with questions for your doctor, things that I came up with that would be good things to ask when you have questions related to neuropathy. All right, so what is peripheral neuropathy? So peripheral neuropathy actually encompasses a lot of different things. On the far left is the most, let me get the pointer, this one over here is the most common type of neuropathy. We call it DSP because it's distal symmetric polyneuropathy, which is a mouthful. But distal just means it starts in the toes. Symmetric just means it starts the same on the left and right. And polyneuropathy just means it affects lots of different nerves. But as you can see, the neuropathy starts here and starts working its way up to the knees before it starts in the fingers, and then starts working its way up the arms. We call this a stocking glove distribution. And most of the talk is going to be based on this type of neuropathy. Other types of peripheral neuropathy include radiculopathy, which is when you have a pinched nerve root in the back, or mononeuropathy, such as if you get a pinching of the nerve at the wrist, such as with carpal tunnel syndrome. These are peripheral neuropathy, but ones that we'll talk about much less. So what happens in a peripheral neuropathy? Well, this is a picture of a nerve cell. Here's the cell body of the nerve, and then it has this long axon that goes all the way out, and for a nerve cell, it goes out to the muscle here. And it's wrapped in with these cells called Schwann cells, and it has a coating called myelin, which is kind of like the insulation of the cell. And this helps you have signals from your brain all the way to the muscle. And this is the real long part right here, the axon. Here's another schematic which is very similar, shows the cell body, the axon, all the way to the muscle cell. And so when your brain says, I need to move my muscle, you have a signal that comes here, down the axon, and then the muscle gets smaller. But the nervous system is very complicated. That was the motor nerve, and these are the sensory nerves. They have an axon. Where's my pointer? Oh, it's all the way over here. They have a nerve cell, the axon, that goes all the way out to your extremity. But then it comes all the way here, and it has its cell body right here. And then it goes all the way into the spinal cord, comes up, crosses the other side, goes up, crosses to the brain. So a very complicated circuit. And this is for light touch and knowing where your feet are, whereas on this pathway is totally different for feeling pain and temperature. So not to memorize this, but this is just a very complicated setup for your nerves. And here shows what the nerves look like. So here, this is a nerve right here, but it's made up of these axons. Each one of these is a different axon, which has the insulation around it. So it's like a wire with the insulation around it. But then we bundle them up a bunch, and then we have multiple bundles and wrap them up, and then you get a big nerve that is something you could see. So here's the axon, here's one fascicle or bundle, and then here's a bundle of bundles. And this is what your nerve looks like under the microscope. And for here, this is normal right here. And what you see is you have the dark staining cover, so this is the insulation of the nerve, and in the middle of the hole is that axon or cable of the nerve. And what happens is you get neuropathy. You can see they start to drop out. You have less of those things, here's moderate, and then finally severe, where you have very few. Here, the nerves are pretty much gone. You just have a couple remaining ones. All right, so now that I kind of talked a little bit about what nerves are and the most common type of nerve, the neuropathy called DSP, let's talk about things that can cause neuropathy, particularly with people with problems with bone marrow. And number one on the list really is the treatments that we can give for these diseases. And this is an ever-changing thing. So I'm not an expert in the different treatments of these conditions, but I was able to look up things that have been used. And these include bortezomib, which is Velcade. And that is a medicine that causes neuropathy quite a lot. In contrast, some of the older medicines like thalidomide also cause neuropathy, but not nearly as much. And then you have lenalidomide, which is very similar, which barely causes neuropathy at all. And I've included the brand name in parentheses, and then this is the more complicated scientific name. And this is just showing that lenalidomide has much less neuropathy than thalidomide. So treatments can be a big problem. What about other treatments? So then there are things like, I'm even going to go to the brand name because I don't know that I can pronounce these terribly well, Bedaza and Dacogen, and they don't really have neuropathy associated with it that we know, although they are newer medicines. Gleevec has some case reports, but again, not a big player. And danarubes and cytarabine, which are usually used for people that are going to get hematopoietic cell transplantation, bone marrow transplants. Again, there are some case reports, but this has been around a long time, and there are very few. So most of these on this list don't really cause a lot of neuropathy. So you can see that depending on which treatment, you need to be very aware of neuropathy or not that worried at all. And here is a list of medicines that came out just in about a year-and-a-half period, January to halfway through 2016. They're not for myelodysplastic syndrome, but they're for oncology, cancer drugs, similar category. And you can see there's just an incredible list of medicines. So this is just to show that this is an ever-changing thing. And the nice thing about all our new treatments is, hopefully we get better and better treatments for myelodysplastic syndrome and things like that. But it opens up, the potential for new medicines that may or may not cause neuropathy. And here's just some of those medicines and how they affect the nervous system. So this medicine, ipilimumab, hurts the muscle. These are inflammation of the muscle diseases. These two medicines, pembrolizumab and nivolumab, affect the communication between muscle and nerve. These medicines, the same couple medicines we've been talking about, cause strange neuropathies that come on very fast. This medicine causes a neuropathy where you pick off nerves here and there, but not in a diffuse systemic way. This one can cause neuropathy that, just like the carpal tunnel where it just hits one nerve. And these medicines, cisplatin and carboplatin, thalidomide, they can all cause a very bad sensory painful neuropathy. So this is just some oncology medicines and all the different types of ways it can affect the nervous system. And this is just what happened in 1 month. You saw 3 different articles that came out describing new neurologic problems after some of these medicines. So not necessarily relating to myelodysplastic syndrome, but just showing you that this is an ever-evolving thing. Okay, so we talked a lot about some of the medicines that people give to treat myelodysplastic syndrome, but what about other types of treatments? And one of those is the HCT right here, which stands for hematopoietic cell transplantation, or having a bone marrow transplant. And what can happen when you have that is you can get graft-versus-host disease. And this basically means where you're trying to get rid of the bad bone marrow, put in new bone marrow, but that new bone marrow sometimes attacks the body, and it can cause symptoms including neuropathy. Also, I learned that renal disease is more common after a transplantation like this, and that's one of the more common causes of neuropathy, as is diabetes, is the #1 cause of neuropathy, and it is more common after these transplantations. So just because you have a bone marrow problem or a treatment, it could be, due to something else downstream, like diabetes or kidney disease. What about graft-versus-host disease? Well, it actually doesn't affect the nerves very often. It really usually is a skin problem and a gut problem. So people get things that show up on their skin, or they have trouble with diarrhea or other abdominal pain. That's quite common, but the nerve stuff doesn't happen very often. But when it does, it can be very strange, where it attacks the covering of the nerve and not the cable, and gives you a very quick neuropathy. And it can also cause damage to the blood vessels to nerves and cause a very painful neuropathy that only affects certain parts of the body. So this is very uncommon, but it happens. What about autoimmune causes? So it turns out when you have problems with your bone marrow, sometimes your autoimmune system or your immune system doesn't work quite right. And while uncommon, your bone marrow, when it's not working right, you can actually have autoimmune problems that develop where the body attacks itself. And that can lead to what's called Guillain-Barré syndrome. And again, this is just a neuropathy that affects lots of different nerves throughout the body. And it happens within a few weeks. There's another version called CIDP, so we don't have to say this long name, which is basically just a very similar neuropathy that comes on much slower. And again, these are conditions where the immune system attacks the covering of the nerves, and fortunately are very treatable, especially if caught early. So these are important to know about, but definitely not common. What else is on this list? So it turns out that there are things that mimic myelodysplastic syndrome, and one of those is not having enough copper in your body. And it can not only hurt the bone marrow, but it can also cause a neuropathy and a spinal cord injury. This is not a common thing, but when people take zinc supplements routinely, that can lead to not enough copper. Denture creams can sometimes lead to less copper for the same reason, too much zinc. And there also is gastric bypass surgeries that don't allow you to take in enough copper. All right, so we kind of finished up talking about all the different things that can cause neuropathy in myelodysplastic syndrome. Mostly, I want you to know that it's the treatments are the main thing. Fortunately, the other types of neuropathy happen only in certain contexts, like having a bone marrow transplant, or having a rare autoimmune problem. So those are uncommon, whereas having neuropathy from a medicine can be more common. And it really pays to know which medicines we're talking about, because some don't hurt the nerves at all, and others hurt the nerves quite commonly. Okay, well, how would someone know that they might have a neuropathy? Well, it turns out that the main symptoms that we talk about are numbness, tingling, pain, and weakness. So numbness is where you have a lack of feeling, and it usually starts in the toes and starts to work its way into the feet and up the legs before it makes its way to the fingertips. And a lot of people describe it as if they were standing on a pebble, where they had a bunched up sock or tape around their foot or a spongy sensation. Tingling can also be kind of a creepy, crawly, pins and needly, or like my foot fell asleep type sensation. The type of pain people usually describe is burning or electric, shooting or stabbing, or an on-fire feeling. And then the weakness tends to be much less than the sensory complaints, but usually the weakness starts in the toes before working its way to the ankles, and rarely affects higher up unless it's a strange type of neuropathy. Okay, so how do we, if we have those symptoms, what would a doctor think about to do? Well, it turns out that the history and examination are by far and away the best things to figure out if someone has a neuropathy. The history is just asking questions about symptoms, and we kind of just went over those symptoms. But on the next slides, I'll talk about the physical examination, different labs that we sometimes order, the role of imaging, such as MRIs and CAT scans, nerve conduction studies, where we shock the nerve and record how big it is, electromyography, where we stick needles in muscles. So these are kind of the tests that doctors think about, but history and examination are by far and away the most important. Okay, so what about the examination? Let's start out with pinprick. So it turns out that a very high-tech way to test for neuropathy is with a safety pin. And we just poke people on the toe and then on their knee and try to see if there's a difference. If there's less pinprick feeling in the foot, sometimes that indicates the beginning of neuropathy. Equally good to try to figure out if someone has neuropathy is using a tuning fork. So a doctor hits a tuning fork as hard as they can, and they put it on the big toe, and they figure out how many seconds you can feel. And it turns out that that's another great way of trying to figure out if someone has neuropathy. So you're getting the sense that it's not, it doesn't take expensive tools to quickly find out if someone has problems with their nerves. A little harder is using a reflex hammer, where doctors often check reflexes in the arms and at the knee, but this is usually the one at the ankle, called the Achilles reflex, and it can be kind of hard if you're not a neurologist. Luckily, it's probably the least helpful of the tests. Strength testing is very important. A lot of neuropathy doesn't affect strength, but when it does, that is a clue that we need to probably do more evaluation. We often have people try to pick up their toes, but even a better way is to probably have people walk on their heels and toes. If they can do that effectively, that usually says that there is no weakness. Other tests that we can do include a tandem gait, and I picture that here, where people basically do, a sobriety test where they're walking heel to their toes, kind of in a straight line, and seeing if they can do that without wobbling. And that's because neuropathy affects the sensation, such you don't know where your feet are without looking at them, and that's how it causes balance problems and sometimes falls. The other thing is a Romberg test, where you see the patient is closing their eyes, standing feet together, and someone's making sure they don't fall. But people that wobble a lot, that happens a lot when you have a neuropathy. So we talked about the different symptoms that people have, and the neurologic exam that is really quick and easy, but can help us figure out usually when people have a neuropathy. As far as labs that doctors need to get, luckily, usually we only need just a few or none. And the ones that are most helpful are these here, which are, a typical metabolic panel, blood counts, diabetes tests. These are things that your doctor often gets anyway. And then ones that are a little more unique to neuropathy include looking for protein in the blood or a B12 level. But you don't really need these if we already know the cause of neuropathy. This is more if you don't know the cause of neuropathy. When people present with strange neuropathies, and we'll talk about what makes it a strange neuropathy, then sometimes we need lots of tests, including EMGs and nerve conduction studies and lots of labs. But this is luckily not the typical situation. And here is the practice parameter from the American Academy of Neurology, saying basically what I was saying on the last slide, which is you need tests of diabetes, B12, protein in the blood, and this is another test of diabetes, because diabetes causes half of all neuropathy. So while we didn't mention it as a big part in the causes, it turns out neuropathy is just common, period. It affects 30% of people with diabetes, and it affects at least a couple percent of people in the whole population, and maybe up to about 5 or 10% in people above the age of 60. So neuropathy is just common, period, and diabetes is always the #1 cause. About half of all neuropathy is caused by diabetes. Okay, what about imaging tests? So I'm showing a picture of a CAT scan and what a result might look like, and an MRI and what the picture looks like. And you can tell that the head CT kind of looks blurry and the MRI looks much more precise. So MRI is usually a better test to look at most things, but is also more expensive. But it turns out, this is looking at the central nervous system, and neuropathy is in the peripheral nervous system. And so usually we don't need these tests unless we're confused about where the problem is in the nervous system. So most times we don't need it, although unfortunately lots of times people get it anyway. What about nerve conduction studies? So here's an arm, and basically what we do is we put an electrode here to shock patients right over the nerve, and then we record over the muscle. And so we shock here and record here, and we look at how long it takes to start to respond, and then how big the response is. And this tells us a lot about your nerves. And here's what it looks like on an actual person where we have our electrode. It kind of feels like a carpet shock. It's a little annoying, but not too bad. The hard part is we do it multiple times, but it's more obnoxious than really painful. And you can see here's where we record for the nerve response. And here's what it looks like when we get it. As you see, we can get how long it took and how big this curve is, this hump. And here's just 3 different examples. So we measure it, and we can figure out if yours are as fast as they should be and if they're as big as they should be. A complementary test that we usually do at the same time is taking a very small needle, similar to an acupuncture needle, and inserting it into the muscle. And here you can also see our reference electrode, but mostly we stick a very small needle into the muscle, and then we can look at what response we get. And here's what the response looks like. We have all these kind of jiggles and things that are the motor units, and that tells us about whether the nerves are injured or the muscles are injured and how long it's been injured. So it's a small needle into certain muscles. We can tell the pattern of injury, nerve versus muscle versus normal, which really tells us a lot about whether or not they have a typical neuropathy or something less typical. So fortunately, these tests are often not needed, especially if we know why you have neuropathy and that it's pretty clear that you have neuropathy. That doesn't prevent a lot of people from getting these when they don't need it, but fortunately, most people don't need this test. As far as when you have uncommon neuropathies, this test is invaluable, and we really rely on it to tell us what kind of neuropathy and what the treatments might be. So we don't need it on most people, but when we do need it, it is incredibly helpful. This is particularly true when we don't know why you have neuropathy. If you got a med that causes neuropathy and then you develop a neuropathy, we kind of know what's going on. But sometimes, you develop a neuropathy and we don't know why. Here are some of I told you there are typical features and atypical features, and here are the features that would make you think, this might not be a typical neuropathy. So neuropathy usually comes on really slow. So if it comes on quickly, then that's something that we usually want to investigate further. unless it's in the context of a medicine that we know causes neuropathy. If it's different on the left and right, that's another thing, that most neuropathy is the same left and right. So this would be a feature to say, maybe we need to do more. Most neuropathy causes a lot of numbness without a lot of weakness. So when there's a lot of weakness involved, that's another warning sign that we might need to do more. And usually it starts in the toes and makes it all the way up to the knees before starting in the hands. If it starts in the hands and feet at the same time, that's another warning sign. Okay, so how do we treat neuropathic pain? Because the two treatments of neuropathy are, one, to remove the problem that caused it in the first place. So that could be, treating diabetes, helping get your kidneys better, not continue to take a medicine that causes neuropathy. But a lot of times we're left with nerve pain. This doesn't happen with everybody. This is probably on the order of 1 in 3 patients with neuropathy. But as you can see from these pictures that people describe, this is not fun. You got all these bugs climbing on you, you got these needles poking in you, you got these hot coals type sensation. These are just some of the pictures I was able to pull from the internet from patients trying to describe their neuropathy. But the good news is we have treatments for them. And the good thing is we have a consensus. There's 1, 2, 3, 4, and now a 5th guideline that all basically say the same thing. So the nice thing is it's not controversial. The data, everybody kind of agrees what works and what doesn't. And here's what people should probably try. The first line is a tricyclic antidepressant. This is Elavil and Pamelor. A serotonin norepinephrine reuptake inhibitor, which is we call SNRIs because that's such a mouthful. This is Cymbalta and Effexor. And then you have these voltage-gated calcium channel medicines, and this is your Neurontin and Lyrica. So you really have 3 classes of medicines that all work about the same as far as we know. And so it makes sense to choose one from each class. Start here, and if that doesn't work, go here, and if that doesn't work, go here. And it doesn't really matter which one you start with. And then you can also combine them. But we basically have 6 really good medicines, 2 in each of these classes. And after that, we don't have good medicines. When I originally put this slide together, this is from one of my papers, second-line therapy was opioids and tramadol, which is another kind of opioid. But we're learning, and I'll show you in slides to come, that might not be the best strategy. Well, and so since these medicines kind of all work the same, takes about the same effect and the same tolerability, how should we choose which medicine? And one could be based on the why they were originally developed. So Neurontin and Lyrica were both seizure medicines. So if you have seizures, then it makes sense to take those. Cymbalta, Effexor, Pamelor, and Elavil are all for depression and anxiety. So if you have one of those conditions, it probably makes sense to treat 2 things with one medicine. Outside of that, there's not a lot to distinguish other than the cost. And so these are the monthly costs. You can see that Lyrica costs $300, and the rest of them are quite cheap on a monthly basis. Usually this is the one I reserve to last. Unfortunately, that's not what doctors do. Usually they start with Neurontin because it's the most popular, and then switch to Lyrica. But probably this should be 6th on your list because of cost. And after a year, this is $4,000 more. So these monthly costs end up being a big deal over time. And we're also learning that out-of-pocket costs are going up for patients. So this is not just the insurance company that's bearing this cost, but a significant part can be for patients too. Okay, so what about opioids? So opioids, do have some evidence that they help with nerve pain in the short term, but we don't have good evidence in the long term. But we know a lot about the bad of opioids. And it turns out that more and more people are starting to recommend against opioids for long-term chronic pain. Opioids are great for surgical pain or pain that's going to come and go. But for long-term pain, they start to not work as your body gets used to them, and they still have all the problems. So in 1997, doctors started thinking, you know what, we're not treating people's pain aggressively enough. And so there was national campaigns to really treat people until they were pain-free, which unfortunately is probably not even possible. But at that point, opioid prescriptions launched. And with that, you can see that overdoses have also skyrocketed through the roof. And this is a position statement by the American Academy of Neurology saying this is not a good idea. And the reason it's not a good idea is, we believe it works a little bit, although maybe just in the short term. But in the long term, we know that it can affect family, it can affect disability, definitely addiction and dependence, adverse events, the side effects, and even overdoses and hospitalizations and even death. So when someone has a terminal illness, maybe this pendulum or this weight can go back in this direction. But for people that don't have terminal illness, usually the downsides way outbalance the upsides for these medicines. Okay, so what other medical treatments do we have? We talked about we can treat nerve pain. We can take away the main problem that's causing the nerve injury in the beginning. And then the other thing is to make sure that we're doing all the things to prevent problems from the neuropathy. And one of the big problems from neuropathy is falling. People fall a lot with neuropathy because they can't really tell where their feet are unless they're looking at them. And so if there are uneven surfaces or little things that we might be able to navigate, if you have neuropathy, you can easily be tripped and fall. Physical therapists can be great for doing some training for balance. And a lot of this has to do with strengthening your hip muscles and also just practicing all the other muscles that can help you balance when you're not feeling your feet. If you're weak at the ankles, we have good braces such as this. We call them AFOs, which is a fancy term for ankle brace. And you can see it wraps around this part of your leg and goes down and basically keeps your foot up. Because when you're weak and can't keep your foot up yourself, when you walk, you end up tripping on your toes. Canes can be very helpful, and this is kind of a medical cane. But some of my patients prefer, fancy walking sticks. So I think this was a couple $100 walking stick I found on the internet. So it can be fashionable. But the key is when you use a cane or a walking stick, you're using your hand to tell you where the floor is rather than your feet. And in neuropathy, the nerves to your feet are affected way before your nerves to your hand. And this is because it's the longest nerves that go to your feet. Okay, and so the last thing I had for you is, what questions should I ask my doctor? And again, it depends on your situation. But let's go through a few, and I'll try to answer these as I go. And then I'm also anxious to answer the questions that you have for me. So I think from a patient's perspective with bone marrow failure problems, I think medications ends up being the most important thing. So if I was a patient and I was looking through the different options of treatments, I would want to know how often this particular medicine causes neuropathy and compare that amongst medicines. Obviously, every medicine has its downside, but it's nice to know how often it causes neuropathy. Some, as you saw, don't cause neuropathy at all. Some very rarely do. But there are things like bortezomib that cause neuropathy quite often. And maybe that's worth it if it's much more effective, but that's a balance. It also might be that some people aren't that worried about getting a neuropathy, whereas others might think that might be the worst thing that they could deal with. And there could be patients that already have neuropathy, and we were talking about neuropathy is so common, especially as you get older, that if you already had neuropathy, then these medicines could make it worse. So I think this is really patient dependent, but a real good thing to ask when you're reviewing side effects. Okay, how will we know when to stop the medication if it does cause neuropathy? So I hate to pick on bortezomib, but because it's a common cause of neuropathy, let's say you were going to start on that medication and you start developing a neuropathy. Is there a certain amount of neuropathy that we're okay with because we want to get the benefits of the medicine? And is there a clear stopping point where if it causes this much neuropathy, we need to stop? And I think doctors treat this very differently. Some might not even have it well thought out exactly when they want to stop, but it might be nice to know ahead of time exactly what's going to trigger in their mind. You know what? It's time to stop. And this might differ from patient to patient depending on how much they want the benefit of the medicine and how much they are trying to avoid neuropathy. Okay, how about which medicine is best for my nerve pain? I think this is a key one because if you have nerve pain, we have we have pretty good medicines for it, and they all work about the same. And so for me, you have the 6 medicines that we talked about earlier. Neurontin and Lyrica are kind of sister medicines. Cymbalta and Effexor are sister medicines, and Elavil and Pamela are sister medicines. And so it doesn't really matter which one we pick, but if you have depression and or anxiety, I would take one of the ones that also treats that. And then I think cost becomes a big issue because of the difference, particularly with Lyrica. And the other thing I think that doesn't make sense is to try 2 medicines in the same class. So if you fail Neurontin, I don't think it makes sense to try Lyrica right away. I would try all the other ones first before coming back to Lyrica. In fact, I use Lyrica last because it's expensive and doesn't have better data than the rest. And that kind of leads me to this question, which is how much does this nerve pain medicine cost compared to other options? And that, the cost is really confusing, and doctors often don't know the answer to this. But that doesn't mean you can't find out. And it turns out that Lyrica probably is always more expensive than the other ones, and the difference between the other ones probably aren't that significant. There's the cost to the insurance company, which is usually a big number, and then there's the cost to you, which is usually a much smaller number. But that really depends on your plan type. So if you're paying most of the medicine costs out of pocket, then it's a huge difference. And even with copays now getting bigger and bigger, that can really add up. And if someone's trying to give opioids for pain, I would ask, is that really a good idea? Maybe it is if you have a terminal illness or not a long life expectancy. But usually when you have chronic pain and not have a terminal illness, then it becomes a much less wise idea, given all the downsides we talked about with overdose, dependence, even deaths, ER visits. This is becoming a national epidemic that's getting a lot of press, and rightfully so. As doctors, I think we went way too far with using these medications. Okay, what about lab tests? Do I need lab tests for my peripheral neuropathy? Usually the answer is no if we already know why you have peripheral neuropathy. And if we don't, then it's usually just a few simple ones, unless you have one of those really weird atypical ones. But you can ask your doctor, which lab tests do I need? And if it doesn't make sense, then maybe you need to see a neurologist. What about, do I need imaging for my peripheral neuropathy? Usually the answer is no to this because neuropathy is the peripheral nervous system, and we usually take only good pictures of the central nervous system. We're not really good enough yet at this point to take a picture of the peripheral nerves and have it really help us a lot. So usually the answer is no, unless we're worried about cancer infiltrating the nerves. There are some reasons to get it, but these should be rare. So if someone's asking to get it, you should at least ask, what's your reasoning? Do I need EMG and nerve conduction studies? This is the stick a needle in the muscle and shock the nerve kind of thing that go hand in hand that neurologists do. And usually the answer is no, especially if you have a typical neuropathy or if we know why you have a neuropathy. Let's say you got a medicine for your myelodysplastic syndrome and it causes neuropathy and you develop a neuropathy. Usually you don't really need that test because it doesn't really help us much. This is really helpful when we don't know why you have neuropathy or if you have some atypical features that make us need to figure out whether or not we need to treat you in a different way. So I would say most people don't need it, but when you do, this test is invaluable. But feel free to question your doctor about why they need it. I don't think some people do it to confirm the neuropathy, but I don't feel like that's a good enough reason to do that test. So with that, that finishes my presentation. Hopefully, the main takeaways are that now we know, what peripheral neuropathy is, the symptoms of numbness, tingling, pain, and weakness. We know how people evaluate it, which that the history, the talking to you about symptoms and the neurologic exam are the most important and pretty simple and quick. Lab tests, imaging, EMG, you don't need it a lot, but when you do, they're very helpful. And then hopefully I've provided you with some good questions for your doctor to try to learn exactly why you need certain tests or things like that. And then I guess probably the biggest takeaway home for anybody with myelodysplastic syndrome is that medicines are probably the big thing that cause neuropathy. Other than, neuropathy is just common as people get older anyway. So, it's definitely not protective against neuropathy from other reasons. And then there are some strange reasons to get neuropathy too, with things like graft-versus-host or post-bone marrow transplant problems with diabetes or kidney problems. So with that, I will take questions, and I really appreciate the opportunity to talk to you guys.
All right. Thank you so much, Dr. Callagan, for your very informative presentation. We did get quite a few questions, and I'll start with our first question, which is from Lee. Lee would like to know, is peripheral neuropathy curable?
Lee, that's a great question, and one we get a lot in the clinic. And it turns out that nerves are easier to hurt than they are to heal. That doesn't mean they don't heal, but they don't heal nearly as well as we would like, and often incompletely. So usually, we're hopeful of taking away the reason you had neuropathy and then making it so that it doesn't get worse over time. Unfortunately, we don't have any really good medicines that help nerves start to heal and regenerate, and that's what we're really missing. So I'm hopeful that in my lifetime, we will have better treatments, but at the moment, it's not really a curable thing. We just try to prevent it from getting worse and treat the pain as well.
All right, thank you. Our next question comes from Bob and Jan. Bob and Jan would like to know, can prolonged usage of cyclosporine used in aplastic anemia treatment cause neuropathy?
That's also a great question, and the answer is that cyclosporine, it may cause neuropathy. There are some reports, but it's very uncommon, and it should not be the first thing people think about because we use cyclosporine quite a bit in a lot of our nerve and muscle problems to treat it as the treatment, and we see very few problems, even in people that are prone to nerve injury. So I would say it's possible, but really, you shouldn't jump right to that because there's probably something else going on.
All right, thank you. Our next question comes from Grayson. Grayson would like to know, does peripheral neuropathy lead to other nerve disorders and or conditions patients should be aware of?
So peripheral neuropathy doesn't really lead to another problem. It affects people, with pain, quality of life, falls, but it doesn't, one thing lead to something else. So it doesn't really make you more prone to another problem.
All right, thank you. Our next question comes from Allison. Allison would like to know, are there risk factors that predispose a patient to peripheral neuropathy?
Oh, you guys asked a good question. So, yes, especially someone that has underlying diabetes, even if they don't have neuropathy, their nerves are more at risk. Similarly, if you have an inherited neuropathy, your nerves are already not quite right, that makes you more likely to have a worsened neuropathy. Alcohol is probably the number 2 cause of peripheral neuropathy. So people that drink a lot, usually more than daily for many years, that also predisposes to people to have a polyneuropathy.
All right, thank you. Our next question comes from Rosemary. Rosemary was on Revlimid 6.5 years and has neuropathy from toes to knees and hands. She can no longer take it. She's asking, will the neuropathy get any worse?
Well, no. So, once you stop the medicine, most neuropathy then doesn't get any worse over time if that was the cause. Now, if you have diabetes or alcohol or other common causes of neuropathy, it can continue to get worse. But a toxic neuropathy caused by medicines should stop when the medicine stops. There are some chemotherapies, particularly the platinum-based chemotherapies, that can keep getting worse for a few months, say 3 to 6 months after you stop, but that's not common, and then it shouldn't get any worse after that.
All right, thank you. Our next question comes from Fred. Fred would like to know, his doctor is recommending a nerve block. He would like to know, how effective is this procedure for peripheral neuropathy?
Well, for the common neuropathy that gives you numbness in both your feet, a nerve block doesn't help you at all. A peripheral neuropathy caused by a pinching of the nerve in the back, it makes a little more sense. Although, unfortunately, the data even for that kind of injection is not very good. So, in balance, I usually recommend people focus away from nerve blocks in the back unless they've already been helpful for them. We do way too many in this country, and the data is unfortunately not very good.
All right, thank you. Our next question comes from Corey. Corey would like to know, are there any contemporary alternative medicine treatments available that would help peripheral neuropathy?
Yeah, great question. So, we don't have a lot of proven therapies. There are a couple medicines that are alternative that have some benefit, like acylcarnitine, but the data is pretty weak to support them. But that doesn't mean that new data won't show that they work. So I would say we don't have any well-established ones, but there are some with a little bit of data that people use, and it'd be great if we could come up with new treatments because we sure need them.
All right, thank you. Our next question comes from Staley. Staley has MDS and neuropathy in their shins. They would like to know, can this result from very high ferritin levels from blood transfusions?
I am not aware of neuropathy that can be caused by iron like that. I don't treat people with MDS that are getting transfused all the time. So I can't say that I've looked that up particularly, but I'd be surprised if that was the cause.
All right, thank you. Our next question comes from Corey. Corey would like to know, when can neuropathy rear its head after chemo treatments? Mine showed up a year later after, I believe, their transplant. They would like to know, is this common?
So usually when it's the medications, it happens pretty early on, at least once you reach a certain dose. So, it might not be the first cycle of medicines. It might be multiple cycles in. But like we were talking about earlier, usually once you've stopped it, it doesn't come on or get worse later, except for some of these where you get, it can last, 3 to 6 months after the last one it can come on. If it's in the context of a transplant, it might be some of these other things that we were talking about, like graft-versus-host disease or diabetes or kidney disease that develop because of it. So it's usually not the chemo itself if there's a big time period between the medicine and when you develop it.
All right, thank you. Our next question comes from Patty. Patty would like to know more about the role of cytoxan during bone marrow transplant in causing peripheral neuropathy.
Yeah, so it turns out that cytoxan is not a big player in causing neuropathy. In fact, it's one of our go-to treatments to treat one of our more common types of immune-mediated neuropathies called vasculitic neuropathy. And so, yeah, we feel like cytoxan is pretty safe when it comes to nerves.
All right, thank you. Our next question comes from Lee. We would like to know, Lee, she's asking, transcutaneous electrical nerve stimulation. She would like to know how safe and which patients benefit.
Yeah, great question. So I would say it's a very safe thing, but there's really no data that suggests that it really helps people with peripheral neuropathy. And so I get very concerned mostly because a lot of times this is like out-of-pocket expenses and people, patients having to pay for it themselves. And so I would be pretty skeptical because it doesn't make a lot of sense that it would work. And any of the studies that have looked at it have not been well performed. So I would mostly say safe, but probably not helpful.
All right, thank you. Our next question comes from Corey, and Corey has two questions. His first question is, when would you consider Neurontin a failure? He's been taking 900 milligrams 3 times a day for 7 weeks.
Yeah, that's a really good question. So, I would say that Neurontin is a failure, or any medicine is a failure, when you've reached the top dose or had a side effect that you can't get past, and you've, tried it for a good, probably, 3 months, and it sounds like you're right up against that because 900 3 times a day is the top dose, and 7 weeks, you're kind of on 2 months, so you're getting close. I might try to give it 1 more month, but then it's probably on to a different medicine.
All right, thank you. And Corey's second question is, how is the cause of neuropathy determined between chemo versus GVHD?
That's a great question. So I think it has to do with timing. So again, are you on a medicine that causes causes neuropathy? Was your graft-versus-host really bad when your neuropathy started? So it's really, sometimes it can be tricky, but a lot of it has to do with the timing of what's going on. Anything that's close to when the medicine was given makes you think medicine. Anything that's close to when the graft-versus-host was flaring up makes you think that. So I would say usually you can figure it out just by knowing what happened and when.
All right, thank you. Our next question comes from Bailey. Bailey would like to know, has acupuncture been helpful to peripheral neuropathy patients?
Good question. I think this goes into similar to the earlier one where, people have tried it, and I think some people's pain gets better, but we don't have great evidence to support that. We haven't had really robust trials to look at it. So it'd be nice to have a good trial to see, does it really help, and should we be adding it to our medicines, because it'd be nice to have some non-medication approaches too. Usually acupuncture is not covered, so usually it's an out-of-pocket expense. So right now I think it's possible because it does seem to help for some other pain conditions, but we just don't have enough data.
All right, thank you. Our next question comes from Corey. Corey would like to know, is there any data on vibration machine therapy for neuropathy?
I don't know what that is, but it doesn't sound like a good idea. Your nerves help feel vibration, but I would think I would stay away from a device like that.
All right, thank you. Our next question comes from Joseph. Joseph would like to know, I am a 60-year-old and just had a bout of a gout affecting his big toe. The gout seemed to exacerbate the neuropathy. Is there a connection?
So the only connection between gout and neuropathy is that colchicine is a medicine that can be used for a gout flare that can also cause neuropathy. Otherwise, they shouldn't be connected.
All right. Well, I believe that was our very last question. Thank you so much, Dr. Callagan, for your very informative presentation and for your time. I would also just like to add that if you would like to rewatch this webinar at a later time, please be on the lookout for an email that will provide you with an archive link within 4 to 7 business days. On behalf of the Aplastic Anemia and MDS International Foundation, I would like to thank each and every one of you for joining us today and making us your resource of choice for information on bone marrow failure diseases. If we were not able to answer your question today, please send it to us via email at help, that's HELP, @AAMDS.org so that a patient educator can respond, or visit our online academy at AAMDS.org/learn for interviews with experts and other programs that may address your question. As a reminder, as soon as I'm done speaking, a post-event survey will appear requesting your feedback. We appreciate your time to complete this survey. Again, thank you for joining us, and remember, learning is hope. This concludes today's program.